objectives. Now, I will be myself talking about the mechanism we have in place to be able to monitor what we are doing. For there is already a substantial action being put in place in several countries. Slide. All our countries at least have subscribed to those high-level commitments. Now, for us to be able to see if we have delivered on those, there is a mechanism, an accountability mechanism that has been developed to enable us to see how we are progressing and be able to change actually strategies if required in order to finally get where we want to be. So on the World Health Assembly resolution, when we adopted it, we agreed to be reporting on it every 2 years. And that will be providing to us opportunities to identify what are the gaps, what we need to prioritize at a given time. This far till last year, we were reporting only on steps, on practical steps 1 to 5. As of 2021, next month, we'll be reporting on 7 practical steps. What is this process about? It's actually WHO and UNICEF that are supporting the process of collection of data that countries are collecting through online surveys. They are collected, analyzed at the level of our headquarters, but then validated by your own countries, by member states. And again, it is available online anytime on the site www.washinhealthcarefacility.org. It's an open source that you can all access. Slide. These 8 practical steps represent actually the high-level commitments that you made. It starts with conducting a situation analysis and an assessment, setting targets and defining a roadmap, establishing national standards and accountability mechanism, improving and maintaining infrastructure. We monitor what we do, we review data when required, and in the process, we ensure that we have the workforce capacity that is required to implement those actions. We indeed engage communities that are at the same time actors and also beneficiaries of all those deeds. And whenever possible, we learn from what we are doing. Next slide. Now, this reporting is just a color coding table, which you are able to fill data online. As of now, I thank you all for your cooperation. We actually went from some 13 countries that have reported last year to close to 25 this year. And we hope that we'll have further reporting available to us. As you could see, we were this far reporting only on the 5th first practical steps, which were situation analysis, baseline assessment of data, national coordination and roadmaps, the adoption of national standards, how was the infrastructure faring in terms of access, and indeed, what was the indicators that were being monitored. This grid shows that we have 4 different colors that are used. As always, it's green when we have achieved the goal or target set. It's orange when we are carrying out some activities, and it's yellow when needs have been identified and plans are in place as well. It's always red when we have not been able to do what we plan to do. Next step. Slide. This is additional countries as they have reported. As you could see, some assessments have been conducted. We have some countries that have coordination mechanism in place. We have also some others that are actually most of the facilities required for waste management, etc. Next slide. And this information is available on the site I have listed earlier on. Next one. Here, I would just say that nearly all countries are in the process of updating their written standards. They exist in a form or another. Some are built into the national standard for water and sanitation. Some others are just standalone for wash in healthcare facility. We conducted an evaluation earlier last year, and that was advising us that nearly 3 in 4 countries were having some work undergoing, and their status was out there with established national coordination mechanism. We noted that fewer than 1 in 3 countries had already planned dedicated with a dedicated budget. Again, we will have a session on finances. Without funding, it's less likely that we'll be able to reach our objectives. Next slide. Those are a few examples of activities or actions being implemented. We listed here that in Ethiopia, they have conducted rapid assessment and then followed by improvement in 74 priority hospitals. That was under the COVID-19 response. In Liberia, they rolled out a national plan, training plan for WashFit. WashFit is a tool that we developed with countries in order to assess the risk along the chain of water and sanitation at the level of facilities in order to be able to take progressively some actions to address the situation. In Malawi, they have managed to improve wash within quality of care effort for mothers and newborns. They've developed investment cases for energy and wash in healthcare facility. In Ghana, communities rate services that they are receiving, and they then contribute to solutions which are tracked through a national health monitoring system. Next slide, please. WashFit, you have heard about it. It's a risk assessment tool that helps to prioritize what we need to do in order to improve the quality of facilities and the behavior of all health agents and patients within health facilities. It is used already in more than 40 countries in order to improve wash services and practices. We had a few countries that were the first to adopt this. We had Chad, Ghana, Liberia, Madagascar, and Mali, but we have more countries already implementing it as of now. It engages facilities staff, managers, communities, and even doctors within the facilities. We are developing a new version of that tool, which will be including the risk related to climate change, and that will be available in the 3rd quarter of this year. It will also cover gender. It will look at integration of the wider health effort that is being carried out. Next slide, please. The 5th of May that is coming is the Hygiene Day. That will be the 2nd time that we'll be celebrating this. It's in fact a campaign that provides an opportunity to reinforce messaging about optimal access and hygiene behavior. By washing hands with soap and water, we very likely reduce the risk of infection. And every second, we save lives by doing hand cleaning. This involves healthcare workers, IPC practitioners, facility managers, policy makers, patients and families. It is also the case for vaccination. In fact, it's everybody's business. I will be finishing there and thanking you for your time. I don't know if we have any question as of now, that we could entertain 2 or 3 questions only on the 2 presentations that have been made right now. You can raise your hand for seeing your microphone released.
Yeah, Guy, there are a few comments regarding, a few comments in the chat that people may not be able to voice. And among them is the fact that water sanitation, IPC, is not a priority in financial allocations. And that's a pity. So that could be one of the ways in which the nations, countries could prioritize, prioritize in terms of budgeting, because that's a necessary part of getting the action done. There's also a comment on the integration of WASH indicators in HMIS, DHIS, to inform policy what actions are needed, or if there is action in that direction. To comment on that as we wait for the participants to put their hands up. Over to you, Guy.
Yes, thank you. This, as we saw on practical step number 3, is one of the efforts we definitely need to ensure we succeed to make happen. It is important to facilitate that process. As we develop roadmaps, we identify indicators, and we believe that all countries will make conscious effort to ensure that HMIS integrate WASH indicators indeed. As for IPC, I believe the session on finances will help us further discuss that issue. We have had a lot of funding availed during the COVID response, but yet again, when we analyze the statistics we get from expenditures incurred, we can very much say that IPC was not fully funded and some actions were not able to be implemented. Maggie, you want to add a word on that as well, please?
Sure, maybe just to add to some of the other questions and comments as well, in terms of how do we get health leaders to engage in that the areas of WASH and IPC are often ignored. I mean, I think the economic and the investment case is quite strong. And in fact, there's many positive externalities of investing in WASH. And when you don't invest in WASH, a lot of your health interventions aren't going to have an impact. Just look at all the efforts that have taken place to get women to give birth in facilities, and we still see a high number of preventable newborn and maternal deaths. So that's one thing. And maybe just second, on the monitoring, there's many examples from the Africa region. I'm thinking of Mali, Rwanda, Liberia, where they have been able to integrate WASH indicators into the HMIS. And obviously you have to align with the timing and the process for those HMIS updated indicator and reviews. But once that's done, it's obviously important to continue to make sure that that data is analyzed and presented, because just including it in the HMIS isn't enough, right? It needs to be analyzed and presented back. So I'll stop there, but thank you.
Yes, thank you, Maggie. And in fact, that is why we think this type of gathering is important to us, for it's an opportunity for us to table and discuss those very issues. we have budget for health facilities. Do we allocate any of those running budgets into improving our wash facilities? Not always. What are the mechanisms we need to put in place for that to effectively happen? It's still matter for discussion, but those processes we have described earlier will certainly help us materialize that. Thank you. With this, we'll be also closing the second session of this meeting. That was to try to understand the need for us to make a commitment and also to develop actions at national level in order to improve access to wash in healthcare facilities. We'll therefore move to the third section of our meeting, which will be what is happening at country level. And for that, I will have the pleasure to first invite the Republic of Burkina Faso. That will be the first to be sharing with us their experience. Can I have the slide, please, for Burkina Faso, Lindsay? And I will invite Her Excellency, the Minister of Health, Professor Charlemagne Marie Ouedraogo. You have the floor. We are making sure your microphone is released. Did you get it?
The speaker is muted, maybe.
Oui, bonjour. Merci beaucoup. En tant que ministre de la Santé, j'ai le plaisir de partager l'expérience du Burkina en ce qui concerne le wash dans les établissements de santé. Alors, comme vous le savez très bien, les conditions préalables pour la qualité des soins dans les services de santé est indispensable. Il faut qu'il y ait de bonnes conditions, notamment la disponibilité de l'eau, l'accessibilité des ouvrages d'assainissement, la pratique des mesures d'hygiène. En ce qui concerne le Burkina, il y a un certain nombre d'acquis qui ont été réalisés. Il y a l'institutionnalisation du WASH à tous les niveaux du système de santé, l'élaboration de curricula de formation sur le WASH, la formation continue sur plusieurs volets du WASH, les directives et documents techniques qui ont été élaborés, la mise en place d'un mécanisme de communication et de sensibilisation sur le WASH, la collaboration multisectorielle sur le WASH et la mobilisation des partenaires techniques et financiers ainsi que la société civile autour donc, de cette préoccupation du WASH dans les établissements de santé. Cependant, quelques difficultés liées à la disponibilité de l'eau potable ont été relevées. Il s'agit de la disponibilité insuffisante en quantité et à proximité des points d'utilisation, la contamination des nappes phréatiques dans certaines zones par les métaux lourds, la faible réalisation des contrôles de qualité de l'eau, la gestion et la maintenance qui sont insuffisantes au niveau des points d'eau potable. Nous relevons également que la disponibilité de l'eau est insuffisante en quantité et en Nous relevons également
de santé essentielle et de qualité. Pour ce faire, et malgré des ressources modestes, Le ministère en charge de la santé et celui en charge de l'eau et de l'assainissement se sont investis dans la promotion de l'hygiène hospitalière à travers une stratégie nationale prenant en compte aussi bien l'accès à l'eau et à l'assainissement que l'accès à l'hygiène des soins. Fort de cet engagement et de l'accompagnement des partenaires, plusieurs chantiers ont été réalisés, comme vient de le présenter à l'instant son excellent Monsieur le ministre de la Santé, et des améliorations ont été constatées. Des défis persistent cependant. Mesdames, Messieurs, au-delà de la situation préoccupante dans les formations sanitaires, le défaut d'eau potable, d'assainissement et d'hygiène dans les ménages est également crucial. D'après le programme commun OMS-UNICEF de suivi, 76% de la population d'Afrique subsaharienne ne pouvait se laver correctement les mains par manque d'eau courante et de savon en 2019. Cela représente plus de 840 millions de personnes dont la santé est ainsi mise en péril. Nous ne pouvons pas occulter l'immensité de ce défi et nous ne pouvons pas occulter notre responsabilité en tant que leader dans nos communautés. Bien que prioritaire, une réponse restreinte aux établissements de santé s'apparente à planter quelques arbres pour restaurer une forêt. Nous devons avoir le courage d'agir et d'apporter nos contributions fortes et systémiques aux problèmes d'eau potable, d'assainissement et d'hygiène en Afrique subsaharienne. Mesdames et messieurs, honorables invités, dans sa marche vers la couverture sanitaire universelle, mon pays, le Burkina Faso, cerne profondément les enjeux liés à l'accès à l'eau, à l'assainissement et à l'hygiène dans les établissements de santé. Et c'est pour cela que mon époux, le président du Faso, son Excellence M. Roch-Marc Christian Kaboré, a pris depuis 2015 un engagement fort, celui de, je cite, « zéro corvée d'eau et un cadre de vie sain pour tous ». Fin de citation. Cet engagement est la traduction de sa profonde préoccupation face au drame quotidien de la majorité de notre population. Il traduit sa ferme volonté d'éradication complète et définitive des problèmes d'eau, d'assainissement et d'hygiène à tous les niveaux. Zéro établissement de santé sans système efficace d'eau potable, d'assainissement et d'hygiène en Afrique subsaharienne au plus tard en 2025, c'est la vision que je voudrais partager avec vous à cette occasion, à l'occasion donc de ce sommet. Mais en plus, je voudrais nous engager tous ici conjointement à affronter l'ensemble du problème et viser résolument zéro corvée d'eau et un cadre de vie sain pour tous et partout en Afrique subsaharienne, au plus tard en 2030, dans les ménages et partout où nos populations en ont besoin pour vivre et s'épanouir. Je fonde ma conviction sur une conjugaison des efforts à l'échelle communautaire, sous-régionale, régionale et mondiale pour réaliser ces objectifs. L'ensemble de la communauté mondiale de la santé, en prenant sa responsabilité de prévention sanitaire, doit avoir le courage de s'attaquer aux douloureux symptômes de la pauvreté que sont la privation d'eau potable, d'assainissement et d'hygiène dans les ménages. Pour ma part, je voudrais vous assurer de mon engagement indéfectible à œuvrer activement avec l'appui de toutes les institutions internationales et de tous les leaders soucieux du respect des droits fondamentaux de la personne humaine pour que tous les engagements pris par le Burkina Faso et toutes les déclarations en faveur de l'accès à l'eau potable, de l'assainissement et de l'hygiène se traduisent en actes et changements concrets au profit des populations de notre région Sub-Sahara. Toutes et toutes engagées pour l'eau potable, l'assainissement et l'hygiène pour tous et partout au plus tard en 2030. Je vous remercie pour votre attention.
Merci beaucoup, Son Excellence, Madame la Première Dame du Burkina. là, je veux aussi rassurer. I would like to confirm that we are recording this meeting and it will be available to all participants. And that will be the case as well for all presentations that will be used during the session. With this, we are continuing those presentations of national counterparts in alphabetical order. I will therefore invite Excellency, the First Lady of the Central African Republic, Madam Twadera. Kindly unmute your microphone and you could address us. Thank you.
Très chères sœurs, premières dames d'Afrique, distinguées et honorables personnalités, en vos rangs et grades, tout protocole observé. Je suis très heureuse aujourd'hui de me joindre à vous pour prendre part à cette vidéoconférence consacrée à la recherche de solutions pour améliorer l'accès à l'eau, l'hygiène et l'assainissement dans les formations sanitaires. Je voudrais, en guise d'introduction, paraphraser l'ancien directeur général de l'Organisation mondiale de la santé, le docteur Tedros Adhanom Ghebreyesus, qui disait, je cite, « Personne ne va dans un établissement de soins de santé pour tomber malade. On s'y rend pour se faire soigner, pour accoucher ou pour se faire vacciner. L'absence de services d'eau, d'assainissement et d'hygiène, communément appelés WASH, dans les établissements de santé compromet la sécurité et la dignité des patients. » Fin de citation. En République centrafricaine, il s'agit d'un programme très important pour le gouvernement dont la gestion est assurée par plusieurs secteurs: santé, hydraulique, les collectivités locales, l'action humanitaire et l'environnement. Selon les résultats de l'enquête sur la disponibilité de l'offre de services de santé dans les structures de santé en République centrafricaine, l'analyse montre que dans les 7 régions sanitaires du pays, une seule région dispose d'une couverture en eau, entre 50 et 75% des structures de santé. Au niveau de 35 districts sanitaires, seul un district sanitaire a une couverture en source d'eau dans plus de 75% de structures de santé et 17 structures sanitaires ont un taux en couverture en eau de moins de 25% des structures de santé. Dans la perspective de l'amélioration de l'accès à l'eau potable et à l'assainissement, ainsi qu'aux conditions d'hygiène et de santé des populations, des études parcellaires ont été menées dans le pays avec l'appui de certaines ONG internationales. Ces études ont montré une prévalence de maladies diarrhéiques à 27,3% et seulement 56,8% des ménages ont accès à une source d'eau améliorée. Il faut noter que malgré la situation sécuritaire du pays, des efforts considérables ont été faits par le gouvernement pour améliorer les conditions de vie de la population, surtout en matière d'accès à l'eau et à la promotion de l'hygiène dans les formations sanitaires. Pour preuve, le professeur Faustin Archange Twadera, président de la République, chef de l'État, a officiellement lancé le 19 septembre 2019 à Bangui les 10 domaines d'impulsion présidentielle de la couverture sanitaire universelle en République centrafricaine. Le 7e domaine concerne l'eau et l'assainissement. Il a expliqué que la couverture sanitaire universelle qu'il a lancée traduit davantage son engagement à garantir à tous les Centrafricains de toutes les catégories sociales, des villes et des villages du pays, l'accès à des soins de qualité. distinguées personnalités, mesdames et messieurs. En créant la Fondation Cri de cœur d'une mère en 2016, je me suis engagée à travers des plaidoyers à contribuer à l'amélioration de la santé de la reproduction pour assurer à la population un meilleur cadre de vie où chaque individu, chaque famille, chaque communauté a accès aux services de soins de qualité de manière équitable et durable dans un environnement sans violence. J'ai donc traduit ces engagements par certaines actions qui certes sont insuffisantes, mais qui m'ont permis de toucher du doigt les réalités des conditions de travail du personnel de santé et les différents services qui sont offerts aux patients en général et aux femmes enceintes en particulier, ainsi qu'à leurs bébés. En 2017, dans le cadre de la célébration de la Journée internationale de la femme, la Fondation a offert gracieusement pendant 2 jours de l'eau potable aux différents points de distribution à toute la population de la ville de Bangui et de Bimbo et Begwa. En 2020, j'ai visité en une semaine les maternités des 8 arrondissements de Bangui et Bimbo et Begwa, ce sont des banlieues. Cette visite m'a permis de m'imprégner de la qualité de service des soins offerts aux femmes enceintes dans ces structures sanitaires, de prodiguer des conseils aux différents prestataires de services rencontrés et de les encourager à améliorer la qualité des soins offerts aux femmes enceintes et à leurs enfants. Pour améliorer l'accès de nos populations à l'eau potable en général et dans le contexte de la COVID-19, j'ai fait réhabiliter 2 forages qui ont été mis à la disposition des habitants d'une localité située à 35 km de la capitale. Toujours dans le cadre de la promotion de l'hygiène en milieu hospitalier, la Fondation a remis à l'association des sages-femmes 500 masques, des cartons de savon et divers dispositifs de lavage des mains pour l'observance des mesures barrières de COVID-19. Ceci dans le cadre de la célébration de la Journée internationale des sages-femmes. Voici en quelques mots les actions que la Fondation a menées afin de contribuer à l'amélioration de la qualité des soins dans les formations sanitaires et surtout pour la promotion de l'accès des usagers à l'eau et le renforcement de l'assainissement et de l'hygiène en milieu hospitalier. L'accès des usagers à l'eau et l'assainissement et l'hygiène des établissements des soins doivent constituer une condition préalable à la délivrance des soins de qualité. C'est pourquoi, en ma qualité de mère de la nation et de présidente de la Fondation Cri de cœur d'une mère, je m'engage à poursuivre ce plaidoyer pour que nos formations sanitaires disposent de services de qualité pour nos populations. Je vous remercie.
Merci. Thank you very much, Your Excellency. We'll therefore invite the third country, which will be the Republic of Guinea. I ask the technical team to release the microphone for their presentation. Can I have the slide? That's Guinea.
Chers participants, bonjour. Monsieur le Président du sommet panafricain sur l'OH, mes sœurs, consoeurs, première dame d'Afrique, honorables participants, mesdames et messieurs, je suis très heureuse de prendre la parole devant ce prestigieux parterre de personnalités et de professionnels de la santé, de l'eau, de l'hygiène et de l'assainissement rencontre virtuelle. Adresser mes chaleureuses salutations au UNICEF dans mon pays, ainsi qu'à charge de ces questions si pertinentes de santé. Mesdames et messieurs, je voudrais avant tout propos vous transmettre les salutations de mon époux, le président de la République, professeur Alpha Condé, qui, comme vous le savez, attache une grande importance à l'accès pour tous à des soins de santé de qualité dans un environnement sain. En ce qui me concerne également, la santé au cœur de mes préoccupations, mais aussi en tant que présidente, transmis ces promotion de la santé sociale, maternelle et infantile. Par le biais de cette dernière, au travers des actions menées partout en Guinée, j'ai toujours été particulièrement attentive à la santé de la mère et de l'enfant dans un environnement qui dispose d'eau, d'hygiène et d'assainissement de l'État à travers plusieurs activités et l'équipement de centres de santé à travers mon pays, l'installation de purificateurs d'eau, l'installation d'unités de production d'oxygène et d'air médical, la réalisation et équipement de forage dans des centres de santé à travers le pays, le renforcement des capacités du personnel médical, sages-femmes, médecins, chirurgiens, oncologues et infirmières. Donc, ça a été l'envoi d'oncologues en Inde et aussi l'arrivée de médecins en Guinée pour former les infirmières. La promotion et l'hygiène et de l'assainissement des centres de santé afin de lutter contre leur insalubrité. La Fondation a participé, entre autres, à l'assainissement de l'hôpital Donka, l'hôpital universitaire Donka, ainsi qu'à l'hôpital Ignace Dine pour l'installation d'un aire de repos et un aire fleuri pour les malades. Ces activités ont permis à la Fondation Prosmi de mener régulièrement un plaidoyer afin de promouvoir les services de santé de qualité. Et au fil des années, les actions que nous avons entreprises m'ont permis de réaliser la nécessité d'avoir dans notre pays, la Guinée, un établissement spécialisé entièrement dédié à l'enfant. C'est pourquoi je me suis engagée à construire un hôpital pédiatrique de dernière génération pour lutter efficacement contre la mortalité en Guinée et de contribuer davantage à promouvoir l'accès à la santé, à l'hygiène et à un assainissement adéquat dans le milieu sanitaire. Mesdames et messieurs, excusez-moi. OK. Mesdames et messieurs, chers participants, le thème de cette rencontre portant sur le OH est une démarche de qualité et du bien-être des populations. Une base de réflexion tangible qui permettra, je l'espère, de produire des résolutions stratégiques dont la mise en œuvre permettra de sauver de nombreuses vies humaines, dont les femmes et les enfants qui me tiennent tant à cœur. Je reste persuadée toutefois que chacun à son niveau ait un effort pour la réalisation des engagements pris pour l'amélioration du WASH dans les établissements de santé. Honorable assistance, pour clore mon propos, je voudrais adresser mes vifs encouragements à tous les participants au présent sommet, ainsi qu'à toutes les personnes qui s'impliquent en faveur de la réduction de la mortalité néonatale, infantile et maternelle, le tout dans un environnement sain, dans tous les établissements de santé de nos pays. Je vous souhaite plein succès pour la suite des travaux. Je vous remercie pour votre écoute.
Thank you very much, Your Excellency, for your speech. May I invite now the technical team in the Ministry of Health from the Republic of Guinea. Please unmute your microphone.
Bonjour, monsieur, bonjour, madame. Au nom du ministre de la Santé, j'ai l'honneur de vous présenter le document de la Guinée sur le sommet actuel sur l'amélioration de l'accès à l'eau dans les établissements de santé. Nous avons notre pays, la Guinée, qui est un pays côtier de l'Afrique de l'Ouest. Je ne vois pas bien. Avec une population... Ouais, mais l'image n'est pas claire là. C'est le truc là. Qu'est-ce que tu veux? La régie, pourquoi? Non, non, on va ici. Oui, allô?
Hello, we can hear you.
Oui,
You
allô?
can continue.
La population de la Guinée fait 12 559 689 habitants. Et c'est l'image qui n'est pas claire là. Ce qui est affiché n'est pas clair.
Oh, we can also see the picture.
Bon, souci technique, ouais. Maintenant, taux de mortalité infantile, 66,0 pour 1000. Taux de mortalité maternelle, 550 pour 1000. Taux de l'accès à l'eau dans les formations sanitaires, 42%. Taux d'assainissement, d'accès à l'assainissement de base dans les fossas. Je ne vois pas ça. Il y a des soucis techniques. 79%. Hygiène de base, hygiène des mains dans les fossas, 70%. Élimination finale des déchets infectieux, 58%. Les étapes, nous avons commencé par l'analyse de la situation et la mise en place d'une base de données. Oui, mais chez vous là-bas, ça ne passe pas dans le moment.
L'image est floue, c'est l'image, les écritures sont floues.
Voilà, c'est l'image qui est floue.
C'est clair, c'est un peu clair maintenant, c'est clair.
Non, 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 c'est pas clair. L'image est floue.
La qualité d'image est au niveau individuel.
Oui, c'est exactement.
Moi, c'est clair.
C'est clair chez nous ici. Hein.
C'est un problème de connexion.
Voilà.
Vous avez un problème de connexion.
On peut continuer, on peut retenir, on peut continuer.
Ouais. Alors, on met maintenant là. L'analyse de la situation est mise en place d'une base de données, d'une base de référence. Nous avons, la situation nationale concernant les services WASH dans les établissements de santé a été effectuée. Les résultats diffusés dans le rapport de l'enquête SARA et du pays et utilisés dans les planifications stratégiques. Ensuite, nous avons les résultats diffusés dans le rapport de l'enquête SARA du pays utilisés dans les planifications stratégiques. La coordination nationale et définition des objectifs et l'élaboration d'une feuille de route. Nous avons un groupe technique de travail existe dans notre pays, seulement il n'est pas formalisé. Les objectifs nationaux concernant les services de WASH dans les états de santé reflétés dans le PNDS, le PNDS et ses plans s'appuient notamment sur ODD6. Ensuite, en troisième position, nous avons fait élaboration et mise en œuvre des normes et des mécanismes nationaux de reddition des comptes. Le pays ne dispose pas de normes nationales pour les services WASH dans les établissements de santé. Mais à côté, il existe un document de normes pour la gestion des déchets médicaux. Et ce document est un peu séparé du WASH. Ensuite, nous avons les services WASH dans les établissements de santé qui sont intégrés au programme, non seulement le PEV, le PNLP, le PNLS, le PNLT, le programme national PCI, le MTN et le Cérémonia. Et en quatrième position, nous avons l'amélioration et l'entretien des infrastructures. Et quelques processus sont mis en place. D'abord, dans le cadre de Wattfish, un point focal déjà est nommé et installé. Ensuite, dans le même domaine de Wattfish, il y a eu le renforcement de capacité au niveau régional des 8 régions du pays et communales et 40 communes de convergence. Et après, ce qui est surtout important, dans la mise en œuvre de ce Wattfish, il y a eu une synergie d'action entre les PTF et les ONG, notamment l'OMS, l'UNICEF, Terre des Hommes, et en appui aux autorités nationales sous la coordination du ministère de la Santé. Et cinquièmement, nous avons fait le contrôle et la vérification des données. Les indicateurs dans les établissements de santé sont intégrés dans les systèmes suivis systématiques SARA 2020 et dans le monitorage intégré. Oui, bonjour. Ouais. Les futures actions envisagées, formaliser le groupe national technique de travail, élaborer une feuille de route du groupe national de travail pour l'amélioration du WASH dans les établissements de santé, poursuivre la mise en œuvre du WASH-FISH, renforcer l'intégration entre les programmes PCI WASH dans les établissements de santé, veiller à l'intégration des indicateurs dans le DHIS2 et veiller à la collecte des indicateurs au niveau du système de monitorage intégré au DHI. Et c'est à peu près les quelques actions que la Guinée a envisagées pour le futur dans le cadre de l'amélioration du WASH. Merci.
Merci bien, Ibrahim.
Thank you very much to the team in Guinea for this presentation. And with this, I will invite the representative from Kenya to share with us their progress to date. Thank you very much, Mr. Kuruma.
Connection.
The representative of Kenya should unmute his microphone to proceed.
Thank you, Your Excellency, the First Ladies, distinguished delegates and participants in this very important Pan-African Leaders Summit aimed at improving access to wash in healthcare facilities in the African region. Kenya, in particular, plays a key role, attaches importance to the provision of safe water and sanitation services to its citizenry. In reference to the strategic goal 6, aimed at ensuring availability and sustainable management of water and sanitation for all, and building upon the goals set forth in the UN Secretary General's call to action on water, sanitation and hygiene in healthcare facilities in 2018, Kenya, amongst other countries, supported the World Health Assembly Resolution 727 on WASH in healthcare facilities in 2019, and the previous annual global meetings between 2015 and 2019, and the strategic discussions in WASH in healthcare facilities. And as a step towards meeting the global target on universal access to basic WASH services by 2030, Kenya has set several goals to herself and has developed policies and strategies and overall stewardship for water, sanitation, and hygiene, as well as water resource management sectors, provide a clear vision and policies for the country. And there's a clear institutional coordinating mechanism with routine sector meetings that are chaired by the respective ministries. And there's a clear legal framework that governs access to water and sanitation, as well as conservation of resources in the sector. And the Kenyan Constitution clearly acknowledges the importance of water and entrenches access to water, safe water, as a human right, and as well as empowering country governments to provide access to water and sanitation services. And all the legal documents are available that include the Water Act towards this end. To this end, Kenya has availed several funding facilities towards the provision of WASH in health facilities. And the total expenditure by the public sector has increased between 2014-15 from $499 million US, to a total of $671 million by year 2016 and 17. And the per capita expenditure has increased from $11 to $15 between 2014 and 2017. The main funders of water resources also have changed from users, and they improved to governments, and especially the national government and the county governments, with an increase from 45 to 30% respectively. To this end, 59% of Kenyans have access to basic water, and about 29% have access to sanitary services, in line with a survey done with WHO and UNICEF in 2019. And the mean availability of standard precaution for infection prevention items, about 65% in our health facilities. Further, only about 12% of health facilities have all items for standard precautions for infection prevention, based on a study and assessment done in 2019 of the Kenya health facilities. To this end, next slide. To this end, Kenya has been committed to the roadmap developed for access to WASH in healthcare facilities, and has conducted institutional analysis and needs assessment. And this has been completed, and but there are still some work being done on that analysis. It has also set targets and defined a roadmap, which includes that the existence of an intersectoral coordination committees to streamline work streams cutting across sorry for that. Kenya has also set targets and defined a clear roadmap. And as I said, there exist clear intersectoral coordination committees to streamline work streams cutting across the various agencies, departments, and ministries. And the next step for the after the commitment spelled in this forum, Kenya is committed to develop a roadmap supported by intersectoral national teams to clearly define the approach, intervention areas, responsibilities, targets, and budget for WASH improvements over the next 5 years. Kenya is also set to establish national standards and accountability mechanisms. We're noting that there exists various WASH and related national standards at different work streams, including waste management. And Kenya will adopt accountability mechanisms to ensure that all facilities meet these national standards. Kenya is also committed to improve and maintain infrastructure, where water and sanitation and hygiene facility improvements, the FIT tool has been implemented in a pilot basis in Kenya since 2015. And Kenya is committed to scale this up with the aim of improving wash infrastructure to meet national standards and keep them operational over time. Kenya is also committed in the last health facilities assessment, infection prevention control indicators have been included in the national assessment tools that will be conducted in 2019. And in coming days, these wash indicators will be integrated into routine data correction and review processes for healthcare in order to measure progress and hold stakeholders accountable. As for commitments, next slide. Kenya has made specific commitments towards achieving the global target of having universal access to basic water services in health facilities, and especially bearing in mind what Kenya has achieved during the COVID pandemic and the lessons learned during the COVID pandemic. And the leadership is committed to spearhead focused country support and tracking workforce development, including equipping the healthcare workers with appropriate skills and proper deployment. And then standards and regulations consolidation and review. And these are geared towards completion of the Kenya Water, Sanitation and Hygiene in Healthcare Facilities Guidelines and Standards by the year 2022. Kenya is also committed to community resources, which include costing and budgeting for infrastructure development and improvements. And governments and partners and donors will increase their investments in WASH and infection prevention and control with ring-fence financing by 2023. Kenya is also committed to monitoring and develop WASH implementation plans and monitoring frameworks which will be integrated to integrate these indicators in the health systems monitoring by 2023. It's committed, therefore, that at least 80% of facilities will have basic water services by 2025, which is geared towards the universal access to basic water services by 2030, as per the current global targets. Thank you, Your Excellencies and distinguished delegates. Thank you.
We thank the delegation of Kenya for their presentation and invite the Republic of Madagascar to share their experience. Kindly unmute your microphone to address us.
Oui,
Would we also have the slide from Madagascar?
Oui, ici Madagascar. Bonjour à tous. Je représente Anna, je représente le ministère de la Santé publique de Madagascar. Tout d'abord, nous voyons ici le statut actuel pour Madagascar. On voit ici sur l'image que 44% des formations sanitaires ont accès à l'eau potable à Madagascar. 58% ont accès aux latrines et 17% effectuent la gestion des déchets médicaux selon les directives nationales. Nous avons une politique nationale de gestion des déchets et ces systèmes d'élimination sont déjà écrits sur la politique nationale de la gestion des déchets médicaux à Madagascar. Slides suivants, s'il vous plaît. Pour les progrès faits sur les 5 premières étapes pratiques, tout d'abord, la première étape effectuée, c'est que nous avons déjà effectué des analyses de situation pour l'année 2020. Sur cette situation, pour alimenter les documents de santé et sur les plans stratégiques de politique nationale ont été aussi déjà effectués. Et le plan de développement de secteur santé aussi ont été consultés pour ces analyses de situation pour l'année 2020. Pour la deuxième étape, ça concerne les feuilles de route pour Madagascar. Il existe déjà des groupes intersectoriels WASH dans les formations sanitaires. Ces groupes intersectoriels, ce sont des groupes techniques qui ne sont pas encore officiels, mais qui travaillent activement. Actuellement, nous avons envisager de... Allô? Nous avons déjà essayé nous essayons de faire Vous attendez? Allô?
Oui, on vous a perdu un peu, mais vous êtes en ligne. Continuez, s'il vous plaît.
Oui, d'accord, merci beaucoup. La deuxième étape, donc, comme je le dis tout à l'heure, c'est sur la feuille de route. Nous allons l'organiser cette année pour qu'il puisse vraiment être opérationnel. Pour la troisième étape, concernant les standards nationaux, nous avons, comme vous avez vu sur le slide, sur l'image, nous avons la guide technique de gestion des déchets médicaux et nous avons aussi la guide technique des formations sanitaires sur l'assainissement et WASH qui sont déjà opérationnels au niveau des formations sanitaires. Ça concerne les gestions des déchets, les lavages des mains, les gestions de menstruelles et voilà. Et sur la quatrième étape, sur la maintenance et entretien infrastructure WASH, nous avons déjà des WASH FIT qui existent. Environ 30 formations sanitaires pratiquent déjà ces WASH FIT et sont déjà opérationnels. Nous avons aussi le comité d'hygiène qui prend en charge la maintenance et entretien des infrastructures WASH. Et sur les cinquième étape, pour les suivis des données, les systèmes d'information de santé ont déjà des données sur les maladies liées aux problèmes des assainissements, problèmes de l'eau. Et il y a aussi les ressources. Attendez, on n'est pas encore sur les futures actions, mais j'essaie de présenter les 5 étapes. Merci beaucoup. Et les ressources aussi, nous avons déjà des domaines, des ressources. Allô? Oui, on peut passer au dernier slide, s'il vous plaît. Parce que c'est fini les 5 étapes. Voilà les 5 étapes que nous aimerons présenter. Donc, ces 5 étapes sont déjà en cours, sont déjà actives, sauf donc pour les feuilles de route qui sont en cours cette année, que nous allons organiser cette année. On peut passer à le dernier slide, s'il vous plaît. Voilà donc pour les futures actions envisagées. Pour Madagascar, il a la recherche-action sur les approches à adopter pour assurer la pérennisation des services WASH dans les établissements de santé. Et il y a aussi l'adaptation et harmonisation des outils sur les interventions WASH et prévention, contrôle des infections dans les formations sanitaires et la considération de l'équité pour les services WASH dans les formations sanitaires. Et en dernier lieu, il y aura l'élaboration du plan stratégique et d'une feuille de route sur le WASH dans les formations sanitaires, comme j'ai dit tout à l'heure. Voilà donc pour Madagascar. Nous vous remercions beaucoup. Merci de votre attention. Merci beaucoup.
Thank you very much, Madagascar, for your presentation. I will therefore invite now the Republic of Senegal to share as well their progress to date in regard to those practical 8 steps.
Bonjour tout le monde. Vous m'entendez? Vous m'entendez? Allô?
Oui, madame la présidente, on vous entend. On vous entend.
Bonjour tout le monde.
Oui.
Donc, au nom du ministre de la Santé et de l'Action sociale, je m'en vais vous présenter l'expérience du Sénégal en matière de WOSH. Juste pour démarrer, dire qu'en fait, l'eau, l'hygiène et l'assainissement sont trois composantes essentielles pour la santé, car constituent un pilier pour la réduction du risque infectieux pour le personnel de santé, les patients et la communauté. Et nous savons que l'absence de services WOSH ne contribue pas à l'offre de soins de qualité et constitue un lourd fardeau économique et social. Maintenant, qu'en est-il au Sénégal? Au Sénégal, en fait, le WOSH est intégré dans une stratégie globale d'amélioration de la qualité, de la sécurité des soins et des services, avec comme cadre, en fait, une direction de la qualité, de la sécurité et de l'hygiène hospitalière et le service national d'hygiène au niveau central, et des comités de lutte contre les infections nosocomiales et des groupes opérationnels, notamment hygiène des mains, bio-nettoyage, stérilisation, gestion des déchets et bon usage des antibiotiques au niveau opérationnel. Qu'est-ce qu'on a eu à faire en termes de progrès? Nous avons fait quand même d'importants efforts qui nous ont permis d'avoir des résultats satisfaisants. Et ces données ont pu être collectées grâce aux enquêtes continues de prestation de services de soins et de santé qui sont effectuées tous les ans par l'Agence nationale de la statistique et de la démographie en collaboration avec le ministère de la Santé. Ces enquêtes nous ont permis d'avoir un taux d'accès à des sources d'eau amélioré à 97%, un taux d'accès à des services d'assainissement amélioré à 97%. On a pu constater que 52% des structures, 88% des structures assurent une élimination des objets piquants, coupants, tranchants dans les conditions optimales et que 58% des structures disposent d'un équipement de stérilisation aux normes. Ça, ce sont les résultats des enquêtes continues de 2019. Nationale hospitalière en matière de qualité et sécurité des soins. Et dans chaque établissement, nous avons un comité multidisciplinaire chargé de la mise en œuvre de la politique. Nous n'avons pas une feuille de route WOSH particulièrement, nous avons une feuille de route technique nationale PCI WOSH. Diapo. Diapo, s'il vous plaît. Diapo. Nous avons pu bénéficier, les leaders du ministère ont pu bénéficier en 2016 d'une formation sur le WOSH Fit. Et au sortir de la formation, nous avions mis en place un groupe technique. Nous avons pu faire des réunions, 2 au total, et élaborer un draft de plan d'action. Malheureusement, ce groupe est tombé en léthargie. Qu'est-ce que nous avons fait concrètement? Nous avons également mis en place 4 unités de fabrication de la solution hydroalcoolique dans 4 EPS, ce qui nous a permis, lors de la pandémie COVID-19, de pouvoir non seulement permettre à la structure qui en dispose de fabriquer la solution, mais de pouvoir appuyer d'autres structures environnantes. Nous avons renforcé les structures en matériel et équipement pour une bonne gestion des déchets biomédicaux et pour une hygiène de main irréprochable. Nous avons pu doter les structures de dispositifs d'hygiène de main, de poubelles, de sachets poubelles, d'incinérateurs. Et même, nous sommes actuellement en train de mettre en place pour une élimination parfaite des déchets, des stérilisateurs broyeurs. À l'heure actuelle, nous en avons 3 dans les structures déjà installées et 10 sont en attente d'être installés pour un total de 18. Nous avons pu élaborer, grâce à l'appui de l'USAID, des lignes directrices nationales sur PCU. Toutes les lignes n'ont pas été élaborées, mais des lignes directrices sur l'hygiène de main, la gestion des déchets et le bio-nettoyage ont déjà été élaborées. Nous avons également formé beaucoup de personnel de santé. Nous avons formé le personnel de santé dans 11 régions sur 14. Et la formation n'est pas une formation théorique, mais une formation théorique d'une journée, mais c'est surtout un coaching sur site sur nos domaines prioritaires que sont l'hygiène de main, la gestion des déchets et le bio-nettoyage. Nous assurons régulièrement la surveillance. Nous avons un système continu de surveillance à travers une supervision semestrielle à l'aide d'une grille. Et ce que je peux vous dire, c'est que cette grille comporte beaucoup d'indicateurs WOSH. et nous menons régulièrement des enquêtes d'infection nosocomiale dans les établissements de soins pour les 5 ans, et la dernière date de 2018 où on a pu avoir un taux estimé à 10%. Nous avons élaboré en 2014 un plan national de gestion des déchets biomédicaux qui a été mis en œuvre et qui est arrivé à terme, dont la révision est prévue cette année au 4e trimestre 2021, ce qui nous permettra de prendre en compte la gestion des déchets liquides, parce que dans ce plan 2015-2020, nous ne prenons en compte que la gestion des déchets solides. Diapo, s'il vous plaît. Diapo, s'il vous plaît. Nous avons fait certes des progrès indéniables, mais nous savons que des défis restent à être relevés pour l'optimisation des services WUSH dans les établissements de soins. Dans ce cadre, nous pensons qu'il faut renforcer les capacités opérationnelles. C'est vrai que les leaders ont été formés sur le WUSH-FIT, mais ce serait bien qu'on puisse former le personnel de soins, car nous pensons que l'outil WUSH-FIT quand même est un outil important. Il nous faudra nécessairement renforcer les installations et les équipements, surtout en matière de gestion de déchets biomédicaux, parce que toutes les structures n'ont pas l'équipement qu'il faut. Mais pour ce faire, il nous faudra forcément redynamiser le groupe technique, réactualiser le plan d'action, le draft existe déjà, dérouler une expérience pilote, passer à l'échelle et intégrer les indicateurs WUSH dans la plateforme DHIS2. Mais pour ce faire également, il nous faudra forcément renforcer la collaboration intersectorielle. Nous faisons le plaidoyer pour le financement de ce plan, car si le plan n'a pas pu être mis en œuvre, le premier plan, c'était faute de financement. Diapo, s'il vous plaît. Diapo, s'il vous plaît. Diapo, s'il vous plaît. Et là, c'est juste une photo pour illustrer la formation sur l'outil WUSH des décideurs, formation qui s'est faite théorique et pratique à l'Institut d'hygiène sociale. Et pour terminer, je dirais que nous avons l'ampoule, nous avons l'électricité, et nous pensons que la lumière jaillira de cette réunion pour nous permettre d'améliorer de manière substantielle les services WUSH dans nos structures de santé, et ceci pour le bien-être des populations. Je vous remercie.
Thank you very much to the Senegal team for this nice presentation. And with this, I will invite the Republic of Sierra Leone to unmute their microphone and address us.
Hello, everyone. Can you hear me?
Yes, we can. Thank
yes,
you.
Coming.
We can hear you. We can hear you.
Can this screen be shared? Is it,
Yes, we
I
can hear.
don't know. Who is sharing the screen? Hello?
It's coming on. It takes a bit of time.
Okay.
We have started sharing.
So,
thank you.
Okay. Okay, good morning from Sierra Leone, and good morning, distinguished excellencies of first ladies in Africa and distinguished guests. I am presenting on behalf of Sierra Leone as the WUSH program manager. The first lady is on avoidable absence because of overlapping activities, but she's of great and interest to be part of this meeting. And to share the experience of Sierra Leone on WASH in healthcare facilities for this important Pan-African Leaders Summit. Sierra Leone has many, hello, can I go on?
Yes, please.
Okay, Sierra Leone, as many other developing countries, has a lot of plans being put in place. One of the main agenda for the country, which is a midterm development goal, is to actually increase access to the population to safe drinking water and sanitation in the country. And as a result of this objective and agenda for the government priority, a lot has been done in terms of setting up coordination platforms, in terms of addressing WASH in healthcare facilities, also working together as a team in terms of meetings with other key stakeholders, other MDAs, civil societies, UNICEF, WHO, and several other partners have been coming on board to actually review documents, policy documents, and adapt national guidelines in terms of addressing WASH in the country as a whole. From the slide, you can see Sierra Leone, actually with a population of 7 million from past data, has 1,365 healthcare facilities, of which 75% of them have WASH services. But however, there are lots of challenges in terms of maintenance of these facilities. And the issues with regards to maternal sepsis is of a great concern like other countries, which is also very challenging. And we all know, or we are actually working towards like other countries to see how this can be addressed. In terms of menstrual hygiene, the First Lady's priority has been moving on. She's moving tirelessly to see how she can provide menstrual pads to school children, which is of a key. And for Sierra Leone, we actually don't have much women with disability, you know, in terms of health facility care as a burden. And the pandemic, for example, COVID, has been an in terms of bringing out infectious control of prevention interventions like hand washing, which has been of increase for the past years to date. Slide, please. Next slide, please. In terms of water availability, it's also a great challenge, as I've been hearing from other countries. When we look at current data that has been from JMP, from UNICEF and WHO, 26% have no services, 53% have limited services, and 21% have basic services in terms of availability of water in healthcare facilities. And when we look at the terms of sanitation, only 11% have no services of improved sanitation in healthcare facilities. And in terms of hygiene data, we are actually constrained in having accurate or sufficient data for hygiene. Waste management, 90% of the healthcare facilities have basic services, and 80% had limited services in terms of waste management, while 0.6% or 37% had no services in terms of waste management. So these are actually huge challenges. Next slide, please. Sierra Leone, again, as other developing countries, have also adopted the WASH Fit tools and the methodologies, and this has been greatly supported by the World Health Organization, WHO World Health Organization, and we have trained up to 104 healthcare facility staffs in the 52 healthcare facilities in 7 districts. and 14 DHMT members in 7 districts. We are actually looking forward to see how this can be rolled out to the remaining districts, because for Sierra Leone, we have up to 16 districts. So in terms of the documentation, we have developed water safety plan and sanitation and hygiene strategies, and then sanitation and guidelines for washing healthcare facilities have been reviewed and also adopted. And this has also been adopted by implementing partners who are actually using these standards and guidelines in healthcare facilities. Yeah, next slide. Water supply for healthcare facility is a major challenge again. And this has been seasonal most of the time, because for Sierra Leone, we have 2 seasons. We have the rainy season and the dry season. And when it comes to the dry season, there is always, or most of the time, challenges in having a functional water services because of the seasonality. And maintenance is actually a very big challenge. There are no funds in terms of to maintain these facilities, and most of the time, because of this breakdown on and off, so it becomes a big challenge for provision of water in the healthcare facilities. And we don't have a costed roadmap with actually I mean, all the amenities that are needed. So improvement of wash services in healthcare facilities is actually very key for us to have a roadmap. And the data for washing healthcare facilities is also limited, because we, apart from the 2017 mixed data, since then we don't have a comprehensive or updated data, which is actually very key. And monitoring and evaluation of these interventions is also a big challenge, because proper monitoring system is not there. We have a monitoring framework as a country, but we have actually not have enough funds to actually see how we can monitor these facilities. Next slide, please. So moving forward, like other states have mentioned, the country's agenda is actually very key. The president's agenda, or the new direction agenda, is very key in adapting all these priorities as other member states. And we also look forward to improving wash services and plans to have budgets, implementation efforts for quality of care, and also ensuring that the prevention and control of antimicrobial resistance and supporting commitment to universal health coverage is actually a key priority by 2023. Also providing technical assistance to government to strengthen countries' system. We actually look forward as a country to appeal to government of Sierra Leone, donor partners, UN agencies, and NGOs to see how we can develop costed national roadmap for improvement of access to wash services, financial support for water and sanitation utilities to monitor, because monitor is very key. Even if a lot of fundings have been done, we need to monitor, because it should be an ongoing intervention to see where the gaps are, where the challenges are, and how it can be well addressed. And also safely manage wash services to be maintained for resilience against future pandemics or epidemics. Also ensuring the availability of critical supply chains, such as for hygiene products, availabilities in markets like consumables, disinfectants. And we actually doing well, because the country is able to provide hand washing, liquid soap. We are able to provide so, but though these are consumables, we need to have that continuity so that at least sustainability can be there for points of use for water treatment and also supplies. Yeah. Next.
Thank you very much for the team in Sierra Leone to have shared your experience on this to date. May I now invite the technical team from the Republic of Uganda. Please unmute yourself. Thank you.
Thank you so much. Your Excellencies, distinguished guests, protocol observed. Thank you for having us to present as Uganda to this important meeting. And we want to look at our status. And our status comes from 3 studies. One is the Joint Monitoring Program report of 2019, then the UNICEF assessment of WASH in healthcare facilities 2018, and the Water Aid study in 2019. The Joint Monitoring Program, which did just 3 parameters of the WASH in healthcare facilities in Uganda in 2019, found out that 31% of facilities in Uganda have basic water, 20% have basic sanitation, and 43% have basic waste disposal. In 2018, however, UNICEF had carried out a deeper detailed assessment in 2 regions of the country, Karamoja and West Nile, and they covered 139 health facilities. In the West Nile area, they found that 85% of healthcare facilities had limited water supply due to lack of water source within their premises, and they relied mainly on rainwater harvesting during the rain season. 100% of healthcare facilities do not know of any written guidelines for helping them operate WASH in healthcare facilities. Next slide, please. And in the same study, 2.4% of the healthcare facilities had a sufficient annual budget. Only 2.4% had a sufficient healthcare budget that would enable them run affairs of O&M in their facilities. And only 20% had adequate staff for O&M activities. Then 40% of the healthcare facilities had functional WASH management committees, the rest didn't have. For the Karamoja region, which is an arid area, and it's understandable, 70% of healthcare facilities had limited water supply. 92% had limited sanitation facilities. For instance, latrines were insufficient and unhygienic. This is a nomadic community, so it's got challenges of sanitation in general, but it still gives us a picture of what it is in terms of hygiene and wash facilities in healthcare facilities in the area. 60% had no written guidelines on O&M, and 5.5% had a functional wash management committee. Only 2% of the facilities had sufficient annual budget for O&M, and 14% used only internally generated facility revenues for an O&M, and 6% had adequate staff for O&M. That gives you a picture of what it is in terms of resources that are available for managing WASH facilities in the healthcare facilities. Next slide. Another study by Water Aid, which is more recent, 2019 too, covered specific health facilities in central Uganda, and this is what they find out. 48.1% do not have access to reliable and safe water supply. 85% do not have safe and private toilets, and of those that had, 51.9% were visibly unclean. 54% did not have adequate hand hygiene facilities, while 57% did not have an efficient healthcare waste management system. 69.2% had annual budget for WASH infrastructure, and almost 61.5% had indicated infection control focal persons or committees. 62% had written guidelines pertaining to WASH for healthcare facility, and 36.9% had staff responsible for cleaning for delivery room receiving training in the last 24 months. This actually shows you the need to intervene seriously in this area of WASH in healthcare facilities. Next slide, and want to look at the progress or on the 5 practical steps. On step 1 of the situation analysis, a national survey has taken place, but data has been collected. Analysis is still underway. On step 2, targets have not yet been done, because those will be done after I've done the study and analyze it properly. Then you can set targets where I want to go and how fast you want to get there. For standards and accountability mechanism, our process is not quite linear. It moves back and forwards. There's been a process that is underway for developing guidelines, and the guidelines are being ratified now. It's in these guidelines that we think the standards and accountability processes will be put in place. So some work has been done in that area, and we'll wait for the validation to be completed. Then we'll be able to have standard guidelines for that. However, there are some guidelines on waste care management that set standards, and this has been guiding operations at that level, at health facility level. On step 4, about infrastructure, we've had lots of gains in this COVID-19 response, with over 99% of healthcare facilities reached with hand washing facilities and disinfectants. The status quo for other provisions remains about the same. We're also seeing the decline in the usage as COVID efforts slightly go down. There's like complacency setting in, but we think more efforts will be done to ensure that these hand hygiene activities go on and are not reducing. About monitoring and review data, we have not done this because we are not information is not part of HMIS routinely collected, but we think we're going to push for it to be included in HMIS routine data collected. We have also moved on the workforce, health workforce. As I said, for COVID, almost each health facility has been reached for training for infection control during the COVID-19 response intervention. Next slide, on monitor and review, we haven't done anything much in that area, like I had said, and the things have been repeated. Sorry, this has been repeated, but to add there, we did wash with training has been embarked on, and some implementation has been done. For community engagement, which is 7, we have not done a lot in that area, but from a little bit of health management committees that have been included in a few health facilities. Next slide. What are foreseen actions? We think quickly we should complete analyzing data and make the report from the national assessment undertaking. And after that, we need to disseminate the findings in the national assessment in high-level meeting to advocate for promoting wash in healthcare facilities. We also need quickly to analyze the guidelines for wash in healthcare facilities. And number 4, we need to scale up wash fit implementation and functionalize the technical working group, which is established under the technical working group for sanitation, but not been functioning very well. We need to make it much more active and support it to move. Then we need to develop a plan to improve wash in healthcare facilities and the attendant roadmap. We also need to put a lot of GI in advocating for sources to be able to push wash in healthcare facilities to the level we want it to be. And then 7, we need to implement the plan and monitor progress. I thank you.
Thank you very much to the Ugandan team. We are now running a bit behind schedule. We have 15 minutes over time, and we require some 10 more minutes for this session. But allow me to suggest here, with your authorization, to have a 5-minute break now, and we will resume where we would have stopped, and then continue with the following session related to finances. So remain connected, but we'll stop the meeting for 5 minutes and we'll reconnect. We will reinitiate discussions shortly after. Thank you. Hello, everyone. May I invite myself back again? Thank you very much for your engagement for the last 2 hours or so. We will continue where we stopped. And I would invite His Honorable Minister of Health of the Republic of South Sudan to briefly address us before we could invite the African Council of Religious Leaders for their commitment. Please unlock your microphone, Honorable Minister. Thank you. I was inviting the Minister of Health of the Republic of South Sudan. Are you online?
Coming on. We are preparing.
No.
Hello, guys. Thank you. We are preparing.
May I then pass on the floor to the...
We are coming.
They are taking their speaking. First Lady's office in South Sudan.
African Council of Religious Leaders for their commitment. I therefore welcome the Cardinal John Onayekan, the Executive Director of ACRR. You have the floor, please.
Thank you very much, sir. First, I am not the Executive Director of ACRL. The person that might be holding that position is my brother and friend, Dr. Kuria Francis. I am the co-chair.
His Excellency, Mr.
You cannot hear me?
I can't hear you. For some reason, your microphone seems not to be on.
Let me check my microphone again.
We are good to go. Sorry.
Hello, can you hear me now? Can you hear me now?
Yes, yes.
Yes, it's all right.
Yes,
we can hear you, Your Eminence.
It's all right.
Yes, we can hear you.
Probably fit into that role is my brother and friend, Dr. Kuria Francis, who is the Secretary General of ACRL and who has done a lot to prepare us for this intervention. I am the Emeritus Catholic Archbishop of Abuja, and along with Sheikh Shaban Mubaje, the Grand Mufti of Uganda, we co-chair this structure called the African Council of Religious Leaders. It is simply a kind of a loose framework to provide a forum for religious leaders across the continent to meet, share ideas, and hopefully cooperate and collaborate. We are happy that you have found time to involve us in this forum, because we see it as a recognition of the role of religious communities in this issue and in many other matters. Of course, what we are discussing now and the WASH program, which is only an aspect of the bigger issue of health services, is a basic need of our people. And it is the primary responsibility of the government, because it is the government that is responsible for making sure that their citizens are in good health. There is no need to belabor the importance of a healthy community, because only a healthy community can prosper and grow. Having said that, the fact is that in our continent of Africa, the faith-based organizations have been very much active in healthcare provision in general. And this is basically for religious reasons, because our religions and our moral imperative expects us to take care of the sick. And we see this in the activities of early missionaries and in the very strong activities of the leaders of churches and mosques all over Africa today. It is in that regard that I'm expected now at this occasion to launch an appeal to all religious leaders in Africa not to relent in its attention for the care for the sick in general, and for the issues that are connected with WASH in particular, namely water, water, sanitation, and hygiene. And this despite our limited resources. As I have been listening in the past 2 hours, it is quite impressive to hear the wonderful effort that various African countries have been putting into this issue of WASH, and I imagine to extend it also to the issue of healthcare in general. But we do know that much more still needs to be done. As I appeal to my colleagues in the religious communities of Africa, we also know that we can do little, since we are not in control of the nation's finances. So our contribution is largely one of collaboration with the state, where this is welcome and possible, or with others too, where we can join hands to serve our people, whether in supply of water, or in poverty alleviation, or even in questions of social and political help to our people. In this regard, as religious leaders, we certainly must have a special attention to the poor in our countries, because the plight of the poor should really be a cause of great concern to us. Thanks be to God, in Africa, there are quite a large network of private health facilities, many of them doing very well. But naturally, by its very nature, a private health facility must operate also from point of view of finance, must operate as a business. The result is that the beautiful private health facilities out there can only serve those who can afford to go to those places, which means the poor, and there are many, the poor are left out in the cold. And if the public health facilities are not working too well, then they really have nowhere else to go. And the religious communities can come in at this stage to make whatever effort they can. And this is where the joint effort of all concerned is really what we will appeal for on this occasion, especially now that in this forum, those who are listening to us are not only government officers, but also men of the international institutions and NGOs. WASH, as I said, is only an aspect of general health care, but it is a basic and an important aspect, especially in our poor countries. Unfortunately, water is becoming progressively rare commodity. People probably of my status as Archbishop Cardinal, I have no problem having water to drink. There's water running in the tap in my house. But I'm aware that the moment I step out of my house, and especially when I go to the villages to get water to drink, to wash hands can become quite a challenge. And the pandemic of COVID-19 has seriously exposed this, to the extent that when we were told that to avoid COVID-19, we must be washing hands regularly and keep hygienic conditions. And then I look at my people and find that they have no water to drink. I was praying to God, oh Lord, do not inflict this grave pandemic on us, because we would have no way of coping with it. So far, so good. But the fact remains that we must do all we can to make sure that water does not become something that is only available to those who are in the position to access it. We thank all those who have contributed so far, and we want to congratulate those governments that have considered healthcare as a major priority in the running of their nations. And I really want to appeal on behalf of other religious organizations, even though things are different from one country to the other, I want to appeal that religious organizations, institutions should be put into the picture and invited to partnership in these matters when it concerns serving our people, especially serving the poorest. As a Catholic Archbishop, I do know that we have quite an elaborate organization through the Holy See, the Vatican, and our various bishop episcopal conferences. Perhaps not every religious community has that kind of arrangement. So maybe this is where meetings like this kind and the efforts of ACRUL can come in very handy. Once again, thank you for giving us a slot in this discussion, and I hope it will not be the last. We promise that we may not have money as religious leaders, but we do have very important things to offer to our people in terms of good ideas, in terms of important things to tell our people as they attend our churches and our mosques every week. May God bless all of you and bless us all. Thank you very much. I rest my case. God bless you.
Thank you very much, Your Eminence, Cardinal John Onayekan. I beg your forgiveness first for the wrong introduction earlier on.
It's okay.
Thank you. Your message is really going where it's ought to go. And thank you very much for your own commitment to this issue. May I now invite the team in South Sudan, where the Honorable Minister of Health will address us. You have the floor. Kindly unlock your microphone.
All right. Okay. All right. Your Excellency, the First Lady honorable ministers, DG of WHO, DG of UNICEF, African region, senior officers, the media, the church leaders, ladies and gentlemen. I am very pleased to be among this special occasion. It is sad enough I should be here with my first lady, but unfortunately, due to the death which occurred last night in her family, she couldn't make it to be here with us. Therefore, my first lady asked me to come and represent her in this especially summit. I am here with her office, technical people from my office and also from her office. And therefore, I'm going to introduce one of our young lady here from her office, from my first lady office, to give us the details of a WASH in South Sudan status. And before I call her upon, as a Minister for Health for the Republic of South Sudan, I am very pleased and honored to be here to share this opportunity with you. I know South Sudan is a long way for us to reach where other countries are as now, but we are trying our best for us to learn and for us to catch up with the world. We also have to be excused because South Sudan is a country who just have a problem for many years after conflict and after conflict and conflict. And therefore, sometimes we can take disadvantage of our movement to improve. We are trying our best, and later on you will hear from our presentation. And I'm very pleased as a Minister for Health for all the what I heard from this summit. That is a very educational and is going really to help us to be used for the reference in order for us to catch up and improve our work. So ladies and gentlemen, now I would like to represent you to this young lady to read out our position. And thank you all.
Your Excellencies, the First Ladies, Honorable Ministers, Director Generals of WHO, Director Generals of UNICEF, Director Generals, senior officials, senior officials, the media, ladies and gentlemen. Today, I'm proudly delighted as we join the World Health Organization and UNICEF for this important summit for the commitment for improving access to WASH in healthcare facilities. South Sudan is committed as proud and to be part of this very important discussion. Water, sanitation, hygiene plays a key role in our health and well-being. The world at large continues to experience recurrent epidemic chronic diseases and other public health and humanitarian emergencies, which poses burden on the health facilities. This cannot be handled and managed without proper water, sanitation, and hygiene. Basic WASH resources in healthcare facilities are fundamental to providing quality care. The global call to action on WASH in all healthcare facilities, including primary, secondary, and tertiary facilities in both public and private sectors, call the recognition of the important role WASH plays in preventing infections, saving lives, and improving quality of care. Nevertheless, the situation in our health facilities in South Sudan is grim. For example, 1, infrastructure. complaints, which is 54%. Water supply, quality and quantity, which is 43%. Hygiene and sanitation, which is 38%. Medical waste management, which is 54%. Vector control, which is 21%. Government of South Sudan, UN agencies and partners are to continue investing more in this critical component of health and well-being. The investment in WASH in health facilities is fully supported and well implemented to have a higher gain in return. Significant amount of diseases would have been prevented through across to safe water supply, adequate situation services, and better hygiene practices. While in this, I have taken some time to reach this stage. We in South Sudan are happy to see that more efforts are being employed to invest in water, sanitation, and hygiene practices in health facilities to enhance the universal health coverage. I would like to thank all the excellencies, first ladies, and here in the meeting, the ministers, the Director Generals, and the World Health Organization, UNICEF team for coordinating this very important event to embark on communities to support water, sanitation, and health facilities. On this occasion, I would like to reaffirm my continued compliment and that of the government of South Sudan to avail support to improve the health services of the people of South Sudan. Thank you very much for your time and attention. Unquestioning the water is life and health is wealth for the nation, and I end my speech. My name is Afol Natalia. I work as the project assistant of Concern South Sudan. Thank you very much.
I thank the team in South Sudan for the message that you have conveyed from your First Lady. Again to all, thank you very much for sharing your commitment and your actions today, your vision for the future. And I know that together we can continue the momentum on WASH in healthcare facility and reach that ultimate goal of universal healthcare for everyone and everywhere. So this type of gathering we are having today has also taken place in other continents. And here we would like to share with you the experience that we have got from the Latin America region. So may I ask colleague to launch the video. We do not have sound.
En ese trabajo articulado, multisectorial, propositivo, solidario, ¿qué podemos hacer las gestoras sociales, las primeras damas, para que en nuestros países sea un hecho y una realidad ese acceso universal a los servicios de salud, pero sobre todo a ese acceso de calidad, bajo principios de adecuado aprovechamiento de agua potable, saneamiento e higiene, y en donde, por supuesto, todas las instituciones prestadoras de servicios de salud cobren una relevancia que merecen?
Los servicios de agua, saneamiento e higiene son básicos para prevenir y controlar infecciones y garantizar la calidad de la atención. Son fundamentales para respetar la dignidad y los derechos humanos de cualquier persona que necesite atención médica y también de los propios trabajadores de la salud.
Hoy más que nunca
somos conscientes que de los servicios de agua, saneamiento e higiene, particularmente en los establecimientos de salud, son esenciales para el cumplimiento de los ODS, así garantizando una vida sana y promoviendo el bienestar de todos a todas las edades y la disponibilidad y la gestión sostenible del agua y el saneamiento para todos.
Thank you very much. Yes, it's a business for all of us. And I am pleased our African First Ladies are equally committed to moving forward this agenda. We will therefore go ahead and move into the finance panel. We will have with us some distinguished leaders and experts within the wash and health space who are joining us today to discuss on how to ensure that this important commitment can actually be materialized. I will introduce all our 4 panelists now, and then we'll move into the discussion straight away. I will start not in, I will just start in, I will introduce the panelists randomly, and I will start with His Eminence, the Cardinal John Onyayekan. He is co-chair to ACRL, the African Council of Religious Leaders. He is a Nigerian prelate of the Roman Catholic Church. At the age of 38, Pope St. Paul II appointed him the auxiliary bishop of Ilorin and ordained him in St. Peter's Basilica in Roma in January 6, 1983. His Eminence participated in the conclave of March 2013, which elected the Pope Francis, and is a member of the highest ranking Vatican Sacred Congregation for the Doctrine of the Faith and the Pontifical Council for the Family. Cardinal John continues to serve in several Vatican appointments. He is the current co-chair of the African Council of Religious Leaders, Religion for Peace, and also the coordinator of the African Council of Religious Leaders, Western Africa Hub. I welcome you, His Eminence. We will also have Dr. Benjamin Park, the chief of the International Infection Control Program at the US CDC. Benjamin is the chief of the International Infection Control Program in the Division of Healthcare Quality Promotion, US Centers for Disease Control and Prevention in Atlanta, Georgia. He began at CDC in 2002 as an Epidemic Intelligence Service Officer in the Mycotic Diseases branch. He began leading the International Infection Control Program in 2014. During the 2014-2015 CDC Ebola response, he was the Infection Prevention and Control Team Lead, and he coordinated as well the CDC infection control effort across the affected countries. In his current role, he is leading the CDC effort to build sustainable capacity to prevent, detect, and respond to healthcare-associated infection globally. I will also introduce Ms. Pauline Okumu from World Vision. Pauline is currently the World Vision International Senior Director for Water, Sanitation, and Hygiene. She was previously National Director for World Vision Lesotho and Swaziland. She has held a number of senior leadership positions at World Vision Kenya, including Deputy National Director, Operation Director, Director Health and HIV and AIDS, and Zonal Manager. She has taken on a number of short international assignments, including a World Vision South Africa's National Director and 1 year in North Kivu. Last and not the least, I will introduce Dominic O'Neill, the Executive Director of Sanitation and Hygiene Fund. Dominique was appointed in his position late 2020. He previously worked for the UK government, the FID, as a senior civil servant in Africa, Asia, and the Middle East. Between 2013 and 2016, he served as the UK Executive Director on the board of the African Development Bank. Dominique is from the UK and has qualifications in environmental, health, and water. He serves now as non-executive director on the board of GAIN. I welcome you all. We are running now off the time, so I will go right to the point. The way we'll proceed, I will ask a question, and one after the other, you will have half a minute to a minute to address the issue raised. As you all know, COVID-19 has highlighted the importance of hand hygiene, especially at point of care in healthcare facilities. Statistics are not shining in the continent in that respect. From your perspective, what opportunities does COVID-19 present to take hand hygiene to scale during the pandemic and way beyond it in terms of facilitating financing for improvement of access to wash services within the health system? Who jumps first? You can just unlock your microphone and share your thought. Thank you.
Okay, thank you so much for inviting us into this very important summit. We are humbled to participate. I'll just share World Vision experience. And at World Vision, we took the step to repurpose 20% of our sponsorship funding towards COVID relief and specifically apply for grants that targeted better hygiene. This has allowed us to work with a larger number of healthcare facilities that planned and provide a large number of hand washing stations. And I also just want to mention that in addition, World Vision has adopted the baby wash approach. And this integrates wash with nutrition, early childhood development, maternal, newborn, and child health to improve health and survival of children in the first 1,000 days of life. That is conception to age 2. To see a lasting change, temporary hand washing stations have been replaced with stations connected to piped water networks. And World Vision has committed to increasing the share of our waterworks that are piped networks, and this will have a direct impact on improving both water quality and hygiene. I also want to just mention that our fiscal year 2020 target for healthcare facility gaining access to hand washing facility was 521 across our 40 priority countries. But we've reached 2,480, and that is as a result of the focus on COVID. World Vision also recognized that no one entity, we've had people speaking, which is very great, can solve the financing issues alone. That is why World Vision has used its funding to leverage other funders to come together alongside and co-invest in projects.
Thank you. You have exhausted your minute. And may I ask the next speaker to come on? Is it you, Dominique?
I'm happy to go next. Thank you, Guy, Your Excellencies, First Ladies, colleagues. It's a wonderful gathering today. I'm grateful for everybody to stay on, for staying on to the end. I've been blown away by the engagement and the high level support on this issue. And that's my point, I guess, really, that without this level of commitment, which is then subsequently translated into national, local plans, budget lines, very tangible demonstration, then the sector is less likely to get the funding. When I talk to our potential donors, what they want to know is, are governments committed, and can we see that? How can we see that demonstrated? And is there co-funding, for example? And can we demonstrate impact and results? So I just urge everybody, as you're thinking and reflecting on the excellent commitment and presentations and plans that have been made, to think how you can do that, so that when we go looking for, as well as domestic resources and commitments, that we can go to external funding partners and to leverage further and greater finance for the issue. COVID just brings all of this into relief. We knew hygiene and sanitation was critical for safe healthcare centres, and this only brings it into sharp relief, and we can use it to leverage it. So that would be my message. I'm conscious of giving other speakers time, so thank you very much.
Thank you. Right in time. May I call you now, Benjamin? Would you open your...
Thank you very much for the introduction, and thank you everyone for joining. I'm very honored to be part of this panel. I think this is a critical topic, and I think now is the time to act on it, because clearly the world attention on COVID has helped to raise this issue to the forefront. And there are three things I think that are important to think about to take advantage of this new momentum around healthcare safety. So the first one is that I think that we should think about how to break silos down, okay? I think that it's important to think about this topic, not just as a water and sanitation issue or an IPC issue or a Ministry of Water issue. This is an issue that touches the lives of patients. This is an issue that touches the lives of healthcare workers even, which are a precious commodity, especially in Africa. So to break down silos, how do we have someone that is responsible for the overall picture of healthcare safety within the healthcare facility? The second thing I want to emphasize is, as has been mentioned by many of the speakers already, is to not only develop the policies and the standards, but also think about even stronger levers. What are the main policies that can be enacted? Is this around payment systems? This is around health insurance systems, and even legislative solutions? Because clearly we need to have very strong messages that show the commitment around healthcare facilities, to show the commitment towards healthcare safety, which includes WASH in healthcare facilities. And the third thing I want to say, if I can, this is very important. I'd save the best for last, so I'm going to say the last one. Excuse me for going over. Is that healthcare touches many different programs, many different vertical programs. We have to have essential to have safe healthcare, including the HIV programs, including malaria programs. So look at these programs, maternal child health programs, and look at their responsibility for providing safe care, and to think about how these funding streams can be leveraged for these purposes. Thank you.
Thank you very much. May I now ask as well His Eminence, the Cardinal Onayekan, to share his thoughts too.
Can you hear me?
Affirmative, go ahead.
Okay, because
no, we lost you. You muted your microphone, unfortunately, by mistake. Yes. No. Okay. No. All right.
Hello. Oh my God.
Go ahead, please. You're fine.
So can you hear me now?
Affirmative. 5/5.
All right. I've only wanted to say in this particular regard about what COVID-19 has exposed, namely that it is not wise to carry on in a way that is basically selfish, taking care of ourselves and our families, forgetting the vast majority of poor people around us, and thinking that all is well. Now, COVID has taught us that all will not be well until everybody is well. And so when we come to the simple question of simply being able to wash your hands regularly, we are now faced with the challenge that is it impossible to put people in a position to be able to wash their hands regularly, not to talk about having good drinking water. I think this is, I hope, what this forum is highlighting, and that our governments are doing many wonderful things. Unfortunately, they are the ones who control our money, and they must find a way of rearranging the priorities of our budget in such a way that the simplest thing is made available to the community and to the citizenship. Here we may talk about the private sector too, but generally in Africa, the private sector is not so well mobilized to deal with this kind of thing. We hear a lot of talk about public-private partnership, but we don't see it in terms of service for the people. This is one area where we might begin to ask questions. My country, Nigeria, has the richest man in Africa, and Alhaji Dangote, and he's not the only rich man in Nigeria. And the rich people are spending their money in a lot of ways. Maybe we can convince them to make water available to the poor people who can't get water to drink. These are issues which I believe is not only political and economic, it is deeply moral and religious. And we do our...
Thank you, Examinas. You have exhausted your minutes there. Now,
yes,
that is very good, all that you have said, and I understand that money seems somewhere, we need to go fetch for it and allocate it where it's most needed. I was expecting to see one coming up with a global fund for WASH in healthcare facility. You have advised us, Benjamin, to run instead to go towards what exists already. The global fund for malaria, the global fund for HIV, or whatever other global fund that exists. You are then calling for us to encourage partnership and coordination. So how can actually all relevant parties, ministries of health, ministry of infrastructure, water and sanitation, finance, and any other entities, name them according to a country, how could they then work together to support budget commitment for WASH in healthcare facilities at country level?
Thank you for the question. Can I start with
you, Benjamin?
Yes, thank you for
Another
the question.
minute.
Since I brought it up, I'll be the first to try to answer this very sticky, thorny question. I think that this answer will vary depending on the country, but there always needs to be someone who is responsible. Who is responsible for safe healthcare in your country? Who is the person, who is a ministry, who is a minister that's responsible for safe healthcare? When the responsibility is spread over many ministries, you can always point to another ministry and say that's their problem to deal with. It's not my problem. So who is a person that's responsible? And this starts at the top, and it starts with legislation, and it starts with even thinking about at the prime ministerial level. The second thing I'll say, that because you mentioned the Global Fund, and this is very important, because of the COVID pandemic, the Global Fund now has the opportunity to invest in healthcare, invest in IPC, invest in WASH and healthcare facilities. So this is something that's very new, and I would encourage everyone in the ministries to go back and look at this opportunity, including WASH and healthcare.
That last leg is still a problem. Maybe, Dominic, you have a say out there.
Thank you. Yes. Well, perhaps I'll introduce myself as the executive director of the Sanitation and Hygiene Fund, set up at the end of last year, and we're set up exactly to provide that sort of support. We're still in the early stages yet. We'll be reaching out to many partners on the call. But as I said in my last intervention, the first question we get when we're talking to our potential donors is, can you demonstrate results? Is there that the demonstrable national commitment to using domestic resources? Because donors and partners are concerned about sustainability. They want to know that they're working in a context where there's strong support and good planning. We will be engaging with our country partners through national costed plans for sanitation and hygiene, which will include healthcare in healthcare facilities, sanitation in healthcare facilities. And that will be a means to demonstrate the commitment, the co-funding, the leadership, that integrated way of working that Ben's described, bringing all those different partners together. That's what we hope, and then we'll be able to put our funding and leverage other funding, because it'll, as I was describing, if we can demonstrate that, then we can attract in further external donors. But this starts at home. This starts with good leadership, as we've seen today, good planning, the commitment and the budgeting of these issues in national budgets, so that we can demonstrate that we have got a strong partner who's committed and who will maintain these in the long term. So we are that fund, but we're starting out, and we can only do that with a commitment that we've seen today from governments and partners to make this all a reality.
Wonderful. Pauline, may I turn to you now? World Vision is out there in all countries in Africa, almost. What's your thoughts when it comes to making sure that last leg is covered?
Yes, I just want to add on the issue of partnership, particularly at the national level. It's essential that ministries work together to determine what specific piece of financing each ministry is responsible for. When something is everyone's responsibility, no one focuses on it, as they think someone else will do it. So while all ministries need to engage in the problem, each ministry needs to know what specific piece they should be budgeting for and how that interacts with the budget lines of other ministries. Now, I also just want to add the issue of advocacy. Coordination at country level is only maintained when there is sustained advocacy from the community level. And experience has shown us that that is why World Vision invests in the community voice action approach, so community members know how to advocate for their rights to clean health facility. This advocacy actually at the county or commune level then gets repeated upward to create a steady drumbeat for change from community voices. So involving that voice at that level is very key. Thank you.
You brought in the word community, and that's where I see, I will now ask Your Eminence, Cardinal. We all turn down back to church, to the mosque in the corner, to our religious ministry, and you are the interface. You are where no one is. You are always there. What do you think? How can we get all work together to make sure that the dollars as well goes where it needs to go to get the right toilet in all health centers?
Thank you very much. Can you hear me?
Affirmative. Go ahead.
Okay. Okay. The greatest pain that people like me have, me and my co-chair, Sheikh Mubaje, bishops and imams and religious leaders everywhere, is that we are the ones who are most in touch with the people at the grassroots. You go to our churches on Sundays, to the mosque on Friday, the community, a lot of people come, especially in Africa. We take attendance at religious worship seriously. You see them, you see their problems, but you are not in a position to address those problems because you do not control the means and the resources. We may build 1 or 2 hospitals, 1 or 2 schools, but we cannot take control of health and education of our nation. We make noise sometimes, and in fact, sometimes we speak so loudly that our politicians and rulers sometimes get angry with us, that we are always criticizing. Unfortunately, for as long as there is problem and that we are seeing it every day, we have no option but to keep shouting, especially shouting on behalf of the community you are talking about now, the people at the grassroots who can shout as much as they like and nobody will hear them. There's a big elephant in the room here, and we have not mentioned him. It's a whole issue of good governance, good management of available resources. We're talking of integrity and to eschew corruption. And the saddest thing, one of the saddest experience I had was to know that my country had lots of money in global fund waiting to be accessed, but which cannot be accessed because simple accountability of what has been received was not forthcoming. Is that the fault of the poor people who are suffering? So we have a serious problem here, and I would really want to hear what any of our political leaders may have to say, if there is any of them on this panel. But as a bishop in a country like Nigeria, and my people in this country know me very well that I don't keep quiet, I believe we need to do more for ourselves. We have enough resources to take care of our needs. We may not have enough to go to the moon next month, but definitely to give water to everybody. If we make that a priority, it is possible. Before we start asking for another global fund.
Oh, I will stop there. I will stop there. Before I come to my last question, yes, thank you, Your Eminence. Before I come to my last question, I would like to invite the audience to a lottery exercise. The first one who will unlock his microphone could put forward a question to the panel. Any question. Just one question. Anyone has a burning question for this panel?
Yes.
Oui, il y a une
Go
question.
ahead, Waltaji.
Il y a une question.
Yes.
Oops, I will go for the two, one in French, one in
Bonjour
English.
à
So
tous.
we start with Waltaji and we will go to Kamara and we'll finish there.
Yes. Yeah, directly, my issue is the resources. The resource is very critical in WASH and healthcare facility. I was just writing on the chart, the health facility, before going to donors, before going to a big level, the health facility, they have every year annual work plan. There is a budget request in that annual work plan. There is a budget, percentage of budget going to drug procurement. There is a percentage of budget going to human resource hiring. There is a percentage to go to all service in the healthcare facility. What percent of that annual work plan budget of the healthcare facility is going to WASH? In most cases, zero, or maybe less than 1% or zero. So
thank you.
Otherwise, we solve this scenario, I think we are still going to struggle with this issue. How we are
Thank you, Waltaji. Thank you, Waltaji.
Thank you very much.
Can I have a panelist to answer this question? Anyone?
I'd strongly agree with that. It has to be, the budget has to be represented in the local, in the center itself and at regional levels as well. And to Pauline's point about accountability, those budgets should be transparent. People should know and have the chance to engage their leaders if they don't think the funding is sufficient.
Thank you. Pauline?
Yeah, and I think health professionals have always known the importance of hygiene, but COVID pandemic has created more understanding from government and community members. So understanding, people have appreciated that. So we are hoping that we'll see a big change in terms of where the budget is allocated to, right from the district level to the national level. So I'm confident with the role, for example, hand washing has been witnessed during the COVID, we'll see some change. Thank you.
Thank you. Kamara? Unlock your microphone, please, Kamara Moussa. Débranche.
Oui, bonjour. Donc, je disais, c'est M. Camara, Moussa Moïse de la Fondation Prosmier en République de Guinée, la Fondation de son Excellence, Madame la Première Dame. Donc, aujourd'hui, force est de reconnaître que toutes les fondations, toutes les premières dames de leur côté font vraiment des actions pour intervenir dans le cadre de WASH. Je voudrais savoir, tout à l'heure, c'est une question liée un peu à la première question, par rapport aux fonds disponibles en ce qui concerne les actions que les fondations, les différentes fondations mènent déjà. Est-ce qu'il y a une stratégie globale pour permettre aussi à la communauté de se rendre compte de ces actions en matière de communication? Est-ce que il y a un plan défini pour que vraiment les actions du WASH et l'ensemble du réseau des premières dames, qu'on puisse avoir une lisibilité sur ces actions, parce que parfois, on a l'impression que sur le plan communicationnel, il y a un manque à gagner. Est-ce que, voilà, il y a une stratégie communicationnelle pour montrer de bout de doigt ces actions et leur impact?
Thank you very much. This question, maybe I would ask any of the first ladies or their offices and technical assistant to address. I think it's where we will get the most appropriate answer. Is there any first lady that would like to address this? Any of those still with us? Or anybody in the panel? But I still believe the first ladies will be most appropriate or more in better position to answer that question. Then they will learn one from each other.
Hello, can I speak?
Yes.
I think the silence of the first ladies goes to the root of the problems that Mr. Kamara has raised. We don't hear too much of what people are doing. So it is not only a matter of informational difficulties. There's a whole question of policy. What is happening, and can we really let people know exactly what is happening and what we are doing? Beyond First Ladies' initiatives, which should not be given all the load of the problem. After all, the Ministry of Health. Beyond that, information can only come if it is based on facts on ground. The people will know when action is being taken, and the people will know when they are being served without any elaborate information technology outfit. And I think this is where we stand.
Thank you, His Excellency. I see Her Excellency, the First Lady of Cape Verde, Ms. Fonseca, would like to say something here.
Bom dia, eu farei uma mensagem na parte final, mas não gostaria de deixar de responder à questão colocada. As primeiras damas, pela visibilidade que têm na sua atuação, elas contribuem muito para chamar a atenção para todas estas situações. Quando visitamos uma instalação de cuidados de saúde e a comunicação social nos acompanha, é uma forma de demonstrarmos o que é que não está bem, de salientarmos o que é que tem sido melhorado. Portanto, o papel das primeiras damas nesta sua ação acaba por influenciar na fiscalização das políticas que são adotadas. Obrigada.
I thank you for your intervention, and with this, I will go now to the conclusion. I will go back to my 4 panelists. Thank you for being still with us. Now, I am inviting your concluding thoughts or remarks on how we can advance and upscale IPC WASH intervention in healthcare facility in the African continent, wisely using domestic resources, while we know we also have issues. We have corruption. We have mismanagement at time. So what will be your last word on this? Who would like to start? I am on the panel again.
I'm coming.
Who jump first?
Well, can I start then?
Yes, indeed, His Excellency.
The question you raised, I think, is certainly appropriate for a bishop, for a preacher, because you are asking for a spiritual advice. Namely, how do we make sure that within our limited resources, the basic needs of our people are met? And the only answer we can get is, let us be our neighbor's keeper. Let us see every member of our community as our own. And those who run government should treat everybody as the members of their families. The scandal of the amount of money which government spends on itself vis-a-vis the basic needs of the people is one of the greatest scandals on our continent. How are we going to get around it? We cannot be changing government every year, but I think we shall continue to let people know that it is in their own long-term enlightened self-interest to take care of the basic needs of the people so that the nation can be more livable and peaceful for everybody. And we can start with what is possible, namely simple water to drink and to wash hands. Finished.
Hello, I'll go next. Thank you very much for the question. I think it was very inspiring to hear the First Lady of Cabo Verde speak, because I think this gets to the way that we can solve this issue. The issue, in my opinion, is not a complicated one. It is at the root related to financing. And financing is related to budgets, and budgets are related to legislative solutions. I think that engaging the public, engaging the civil society is the way to reach legislators, and it's the way to reach budgets. So I think continued advocacy at the patient level, but also at the legislative level, at the parliamentary level, will be critical, because there has to be money, and the way who controls the purse strings, it's usually the parliament. Thank you.
Okay, I'll go. I just hello. Okay, I just want to highlight on the fact that co-investment should be considered whenever we have outside funding available, for example, to the district contribution that can be matched. This helps overcome the large investment needed upfront, but also increases district budget lines to ensure long-term sustainability. And then the other thing that I also just want to add is always start with engaging the community and listening to their voices. Healthcare facilities are meant to serve the surrounding population. And when we are making large investments, we should ensure investment are holistic and take into account the needs of the community, even if those needs are larger than the traditional wash sector. And lastly, in all points of care at healthcare facilities, piped water systems are the best option. In order to maintain functionality and sustainability, robust operation and maintenance of schemes should be considered, as well as insurance schemes. That way, users are protected from huge costs when repairs are needed, because I think we know some of those challenges that come with functionality after. Thank you.
Thank you. Dominic?
Perhaps, Guy, thank you very much, and thanks to everybody for holding on. Just to reiterate from our side, this is superb. It's great to raise a profile, but we need to now take it to the next step to maintain that, to maintain the advocacy. But we now need to turn these into plans which can be properly financed. In the first instance, by through public budgets and planning, and in that way we can then go and use that to leverage further resources. They also need to be owned at the national, at the local level, but as has been stressed also by the community, and in terms of the planning, but also in holding those public institutions to account, to ensure that the right solutions are made, that money is spent in the way it should be, and that they are managed in a sustainable way so they don't fall into disrepair. And the last point I'd make is that in terms of raising resources, the more we can demonstrate about good delivery, good impact and change, the more we can all use that to raise more resources externally and to achieve even greater things. So let's move into those definitive action plans, financed. Let's ensure great national, local, community ownership, and let's ensure we can all demonstrate good results and keep it all moving forward. Thank you.
Thank you very much. I think in your conclusion, when I sum it up, I just retain a few words: ownership, accountability, transparency, people-centered, and good.
Alors, excusez-moi, je vais intervenir.
Oui, Son Excellence.
Oui, c'est pour dire ceci.
Yes, yes.
J'ai écouté tout le monde. Je remercie l'assistance. J'aimerais dire tout à fait ce que Madame Okumu a dit. Je vais dans ce même sens, c'est-à-dire pour la gestion des ressources, il faut de la transparence. Donc, comment obtenir ces ressources, ça a été dit, c'est soit au niveau national ou international. OK. Une fois que les ressources sont en place, il faut veiller à ce que ça soit géré de façon rationnelle et aussi transparence et désintégrer les services. Que tout ne reste pas au sommet. Il faut aller donc vers les centres de santé, responsabiliser les chefs des centres en leur confiant des petits budgets pour la gestion quotidienne. Donc, je pense qu'en le faisant, tout le monde gagne et la population aussi gagnera fortement dedans. Que ce ne soit pas d'une manière descendante, que ce soit de la base vers le sommet. Merci.
Thank you so much for those wise words that add to my list of words. I want to thank you all for your contribution. I'm talking to the panelists. That was a very rich discussion. I thank as well the contribution we got during that small discussion. Kamara, Waltaji, Her Excellencies, the First Ladies that intervened. We will then be closing this section of the meeting and enter into the closing of the summit, closing section of the summit. And for this, I will invite my director within the Healthier Population Cluster to address you. Dr. Onyango, you have the floor.
Yes. Thank you very much, Excellencies, Honorable Ministers, distinguished ladies and gentlemen. This has been a very stimulating more than 3 hours of encounter, and I really would like to thank you for holding out and waiting till the end, that we're going to listen to the final words from Her Excellency, the First Lady of Cabo Verde. I think before I give her the floor, I'll just mention some of the key words that are coming out of our conversation today that we can take home. Demonstrable national commitment. That commitment has to be translated into actions, and those actions depend on plans, budgets, and targets, so that we know where we're coming from, where we're going, and the resources to get us there. Progress monitoring, because we need to know and course corrective necessary. Clear responsibilities of individual sectors, ministries, but also individual persons who take this as a personal calling to support others, to help everybody reach, have access to water. And then it's a shared responsibility. So there's a multi-sectoral approach. Many people need to come together for this to work. And finally, very important words, good governance, integrity, accountability. I think if we take on those words and make them our own, we are going to invest even more. So now I have the pleasure and honor to invite the First Lady of Cabo Verde, Her Excellency Lydia Fonseca. Over to you. Obrigada.
Muito obrigada. Cumprimento todos que estão a participar aqui nesta cimeira e agradeço o convite que me foi feito para expor aqui nesta sessão de encerramento. Cumprimento as senhoras primeiras damas, aos senhores e as senhoras responsáveis pela área de saúde, água e saneamento em cada um dos países, as excelentíssimas senhoras e excelentíssimos senhores representantes das organizações internacionais, ONGs, organismos de financiamento, minhas senhoras e senhores, distintos convidados, como já disse, saúde a todos, com muita solidariedade e fraternidade. Agradeço aos organizadores todos os intervenientes pelas importantes contribuições, informações e motivações que têm sido transmitidas. Nesta manhã já vimos o grau de cumprimento dos objetivos WOS de um modo geral no nosso continente e alguns países em concreto. Das intervenções feitas também ficamos a conhecer os desafios e constrangimentos que ainda precisam de ser superados, bem como os compromissos das entidades financiadoras para canalizar recursos para que os países possam prosseguir os seus esforços para a integral realização dos objetivos WOS. Quando, em 2018, a Assembleia Geral das Nações Unidas proclamou a Década Internacional para a Ação Água para o Desenvolvimento Sustentável, que começou no Dia Mundial da Água em 2 de março de 2018 e termina no dia 22 de março de 2028, o mundo estava longe de poder imaginar que no ano seguinte apareceria uma pandemia cuja forma de controle e prevenção assenta grandemente no uso da água. A pandemia de Covid-19 expôs o mundo aos muitos desafios de saúde pública que as populações em dificuldade em todo o mundo, em todo o continente africano, enfrentam regularmente. Esta pandemia, contudo, é um forte lembrete da necessidade de assegurar o acesso adequado a bens e serviços essenciais aos nossos hospitais, unidades de saúde e centros de parto para prevenir a doença. Atualmente, a maioria das instalações de cuidados de saúde no nosso continente não pode sequer fornecer bens de primeira necessidade, água, saneamento e serviços de higiene a doentes e profissionais de saúde. O acesso à água é frequentemente limitado ou inexistente. Não há casas de banho disponíveis ou, quando há, não funcionam e falta sabão. Estas condições inaceitáveis não se devem ao coronavírus, mas a pandemia realça a urgência do problema. Os serviços de água, de saneamento e higiene são fundamentais para a prestação de cuidados de saúde. Efetivamente, precisamos de água segura, limpa e disponível para ter uma vida decente. Precisamos de saneamento básico para uma boa saúde e bem-estar. Quando há escassez de água e saneamento básico, todos nós sofremos porque somos forçados a comprometer a nossa saúde e dignidade humana. Gostaria de realçar que a desproporção do sofrimento das mulheres é ainda maior, pois estas carecem mais de água nos períodos menstruais e a falta de instalações sanitárias adequadas e com alguma privacidade expõe as mulheres a mais violência sexual, incluindo nas estruturas de saúde. Todas estas situações deixam-nos profundamente apreensivos, mas temos o dever de reagir e trabalhar para ajudar a alcançar até 2030 o objetivo de garantir a disponibilidade e a gestão sustentável de água potável e do saneamento para todos. Na qualidade de primeiras damas, temos um grande e forte campo de intervenção e de influência nas nossas sociedades. E por isso a nossa voz e a nossa ação são instrumentos poderosos e eficazes capazes de contribuir para uma maior sensibilização para a necessidade de garantir o acesso do WOS nas unidades de cuidados de saúde. Como ouvimos pela voz das primeiras damas que partilharam aqui as suas experiências, a visita frequente aos estabelecimentos de cuidado de saúde ajuda a avaliar as condições do WOS e a tornar público o que precisa de ser feito para combater as deficiências. A voz das primeiras-damas também deve ser ouvida no apelo para que os governos dos seus respectivos países adotem planos estratégicos e afetem mais recursos para os objetivos do OSH. E a Organização das Primeiras-Damas da África para o Desenvolvimento é, como toda a gente sabe, uma instituição capaz de mobilizar financiamentos internacionais para ajudar as organizações nacionais dos nossos países nos seus esforços do OSH, designadamente nesta vertente referente às instalações de cuidados de saúde. Uma particular atenção deve ser dada nas instalações de saúde destinadas à realização dos partos. Não podemos permitir que as mulheres e os recém-nascidos continuem a morrer na hora do parto ou logo a seguir devido à falta de água para higienizar os médicos, parteiras e outros agentes de saúde, ou ainda por falta de saneamento e higiene nas próprias infraestruturas. Um último apelo que faço tem a ver com a educação. Sendo a água um bem precioso, mais precioso ainda em países como Cabo Verde, que enfrentam graves dificuldades para a obtenção da água para o consumo das suas populações e para a agricultura, é necessário uma aposta muito forte na educação das pessoas, das crianças, na educação para a importância de usar bem a água, da higienização pessoal e dos espaços, bem como as regras para a proteção das infraestruturas de distribuição de água e de saneamento. Como primeiras-damas, como mães das nossas nações, como carinhosamente muitas vezes somos chamadas, aumentemos os nossos esforços e concentremos as nossas ações nesta nobre e importante tarefa. Imitamos, portanto, o nosso próprio apelo à ação. Isto é, traduzir-se-á no nosso compromisso comum, na nossa liderança por esta causa. Todos nós temos uma responsabilidade compartilhada para mudar o futuro OSH na nossa nação. Façamos que cada gota d'água valha a pena. Muito obrigada pela vossa atenção e declaro encerrada esta cimeira. Obrigada.
Thank you. Thank you. Thank you very much. Thank you very much, everybody. Thank you for staying till the end. And now for action. Thank you. Bye.
Goodbye. Thank you.